that from the start. And I think that should pop up for everybody. But so welcome to our Wednesday morning Grand Round series. Today we have our first visiting professor of the year. And so for our introduction, I'll turn it over to Dr. McLeod.
It's really a great honor to actually have Dr. Schemitsch here. He should have been here giving this virtual presentation in San Francisco because he's been in our trauma course ever since it started 15 years ago. For those of you who are wanting to come to the course, here's a shameless plug to work your way down to the Intercontinental Hotel for the next 3 days. So there's one extra room open from Dr. Schemitsch. They did finally cancel the hotel room. So I have known Dr. Schemitsch for about 20 years, and it's been remarkable to actually see his career grow over this time. He's certainly one of the world thought leaders. We will hear a talk from him today about evidence-based medicine and orthopedics, and he's been one of the proponents of that, and probably isn't a better person available to talk about this topic. He's a model of a successful clinician scientist. His training was at the University of Toronto, and then he did fellowships at Harborview and Harvard before returning. He's pretty much held leadership positions ever since I've known him. He was the chief at St. Michael's Hospital, which rapidly became one of the shining stars of clinical research groups and clinical excellence coming from Toronto. And certainly it was something that when we were trying to work on the Orthopedic Trauma Institute, we took into account how they were so successful. He's been a leader throughout. So he's one of the I don't know any other people who's been the president of the CORS, Canadian Orthopedic Research Society, president of the Canadian Orthopedic Association. He's the president-elect of the Orthopedic Trauma Association. He's was one of the founders of the OTA's Basic Science Focus Forum. And so he's had a huge impact on orthopedics. He's able to talk about any subject, so complex upper lower extremity. We heard from the case presentations today that he's also created a niche in periprosthetic fractures. From a research standpoint, there are very few more productive than Dr. Schemitsch. You look at his CV, he's got over 450 publications, over 1,000 presentations. He's had awards, the Bovell Award, which is given the best OTA paper. He's won it been co-author 5 times, which is unprecedented. Canadian Orthopedic Society Founders Award, the NEAR Award, the Canadian Orthopedic Association Core Award, and the International Society for Fracture Repair, a 2-time Best Paper Award. So he can talk the talk and knows a lot about this subject. So I would like to have everyone give Dr. Schemitsch a virtual round of applause. Thank you for joining us, and look forward to hearing us talk about evidence-based medicine. Is there a way forward in orthopedic surgery? Emil, thank you again for being here.
Thanks, Ted, for those remarks. Drew, I am struggling to share my screen. So
let's see. Do you have the green button down at the bottom?
Yeah, I click on that, and then I get my desktop, but there's like a yield sign with an exclamation mark. And then when I click on that, it says allow Zoom to share your screen, open system preferences. So I'm just not sure what I'm supposed to do here.
Let's see. Would you want to email me your slides and I can display them through my screen?
I can try that, but maybe too big to email. So I can Dropbox it or something. I could try and email it. I feel like it's going to be massive though.
Emil, if you try to share any screen, can you? Any screen that you pull up? So if you just hit screen share.
Well, I have desktop, whiteboard, iPhone, Safari, unknown, universal access are the things I can click on.
Are there any windows? How many windows are open on your screen?
3.
Close all of them except for Zoom and for your presentation.
If you share your desktop,
Maybe 1 sec.
okay,
Oops, something's happening.
yeah, looking promising.
Sorry about that. It's just not doing what it normally does, but I don't know if you are seeing that, hopefully.
It's blank. It says that you started. Oh, there
There.
you go.
It's loading, I think, right now.
Got it, Emil.
Yeah, we see the screen now. It looks great.
First side.
Okay. All right. Sorry about that. No, it's great to be here this morning. I'm going to be giving a talk entitled Evidence-Based Medicine. Is there a new way forward in orthopedic surgery? Advance. Okay. My disclosures are listed on the Academy website. This is just a picture showing Toronto, where I spent the first 20 or so years of my practice, top half of the screen. On the left, you just see a panoramic view of the city. You see the CN Tower, which essentially opened in 1977, was the world's tallest freestanding structure at the time. That's sort of an iconic view of the city. And then on the right upper is St. Michael's Hospital, which is an inner city, a level 1 trauma center, where I worked, as I say, for more than 20 years. Bottom half of the screen shows where I'm at right now, which is University Hospital in London, Ontario, at the University of Western Ontario. So if you're participating in clinical research, I think success, if you're looking for that, I think is based on 2 key questions. And those are, is the research question important? And I think a lot of people struggle when they're trying to define a research project in terms of being able to come up with a research question that's important. And I think you really need to ask yourself, is the study design appropriate and feasible? So how can impactful research be done? I think it's really based on finding common problems. So for example, hip fractures, ankle fractures, wrist fractures, proximal humerus fractures, things that are very common. And so you'll have a source of patients in terms of which to actually do research on. Important to be able to evaluate basic techniques to ensure that the techniques are globally relevant. And I think really critical if you're going to be doing impactful research is having the right collaborators and mentors. I think the most important resource when you're doing research is a collaborative group of investigators. And I think if you're looking at what are the attributes for a collaborative group, I think it's a lot about the people more than anything else. So in this study, they looked at what is important in a collaborative group. It's obviously having competence and knowledge, but having the right kind of individuals, people who are cooperative, motivated, and flexible. In terms of the ABCs of research, I think it's really always around being collaborative. And most of the groups that I've had something to do with, the Canadian Orthopaedic Trauma Society, these various study groups have always involved collaborative investigators. And it really is a team story, so that when you look at how it is that you get to being successful, it's really all about the team. So for example, if you look at the Canadian Orthopaedic Trauma Society, which I've had a lot to do with, there's a lot of surgeon collaboration. So there's 60 to 70 surgeons involved in that group. We're all equal partners that contribute. There's a research coordinator network of 50 or 60 research coordinators that collaborate with each other. We do it in a publicly funded healthcare system, which is supportive. Academically, we get along. So we have group authorship in COTS. And so understanding that everyone is going to contribute and their contributions are going to be valued, I think is really important. We have strong connections with industry and our national organizations, the Canadian Orthopaedic Foundation and the Canadian Orthopaedic Association support us. So if you look at COTS, it's been really focused on RCTs, and RCTs are important because they're the best available evidence for treatment efficacy. They control the timing and the amount of intervention. They minimize the chance that factors outside the control of the researcher affect the results, and they limit bias, which I think is really critical when you're doing clinical research. They establish cause and effect, and they balance groups for measurable and immeasurable confounders. And this has really led to numerous publications that talk about treatment efficacy that I'm just showing you some examples of work that's been published through COTS. So when do RCTs make sense? COTS is really focused on them. It's when the prognosis and predictors of outcome are well understood. So there are no flaws or biases in the methods for selecting and randomizing patients, when the options for management are straightforward and expertise is a lesser issue. So for example, this is an RCT which we presented recently at the OTA and was just recently published in the Journal of Orthopaedic Trauma. It's looking at how do you manage the ulnar nerve in a distal humerus fracture. So if you're going to treat a distal humerus fracture, you're going to treat it with dual plate fixation through a posterior approach. There's been a lot of controversy in terms of how do you handle the ulnar nerve. Do you leave it in situ when you're finished, or do you anteriorly, subcutaneously, or intramuscularly transpose it? So that's been a source of controversy, and it was something that we felt could be addressed with a randomized controlled trial. So in this setting, we know that what the predictors of outcome are following distal humerus fractures. We need evidence around treatment efficacy in terms of how to manage the nerve. There's really no bias in selecting and randomizing patients because everyone's getting surgery and you're just trying to figure out what to do with the ulnar nerve. So the management options in this setting are straightforward, and expertise is a lesser issue. So, pretty much anyone can, put the nerve back or transpose it subcutaneously. So it's perfect for an RCT. And so in this RCT, looking at decompression versus transposition, we found no difference in outcome. We found no difference in functional outcome on various outcome scores. DASH, for example, here, out at 2-year follow-up. And on nerve conduction studies, although we found significant abnormalities with all approaches, there was no difference between decompression and simple transposition. So based on this RCT, we were able to show that patients do develop a lot of ulnar nerve symptoms post-surgery, but there's really no difference between anterior transposition and leaving the nerve in situ. So it's really up to the surgeon. So it's a good example of how to address an important clinical question with an RCT. This is another example of an RCT being helpful in terms of answering an important research question. So this is a study that I was involved in called the FAITH trial, looking at whether or not you should treat operatively treated femoral neck fractures with either a sliding hip screw or multiple cancellous screws. There's been a lot of controversy in terms of best treatment. So that's led to the need for, a very large trial. And, an RCT in this setting makes a ton of sense. You understand prognosis and predictors of outcome. There's really a question in terms of treatment efficacy. Is it better with a sliding hip screw or cancellous screws? There's not a lot of bias in terms of selecting and randomizing patients. They're pretty much all getting fixation. And you're really trying to figure out, what is the best method of treatment. The management options are straightforward. So most surgeons know how to do cannulated screws and sliding hip screws. And so expertise in this setting is a much lesser issue. So in terms of doing this study, looking at a sliding hip screw versus cancellous screws and risk of reoperation over 24 months, we randomized over 1,000 patients, had follow-up in almost 90% of patients, and essentially showed between sliding hip screws and cancellous screws, overall, there was no difference in terms of outcome, in terms of reoperation at 24 months. But importantly, we did find that in displaced fractures, there was an advantage of the sliding hip screw. So I think for me, that says that, if I'm going to use internal fixation, it pretty much makes no difference if, you have an undisplaced fracture. But if you have a displaced fracture, you probably should use the sliding hip screw. And I think that really is important in terms of guiding practice. So this study established no difference in reoperation rates overall for patients randomized to sliding hip screw versus cancellous screws overall, but there was a strong rationale for the use of sliding hip screws in patients with displaced fractures. So if you look at those two trials, and you look at sort of the hierarchy of evidence and evidence-based medicine, you would put those two studies, at the top of the evidence pyramid, well above, these other studies, cohort studies, case control studies, cross-sectional survey studies and surveys, and kind of rightly so. But, if you look at sort of climbing a mountain, it's pretty hard to get to the top. And really, it's a process. So, for example, if you're climbing Mount Everest, you're going to go through base camp. And you're going to do a lot of preparation to get to the summit. And prospective observational research, I think, is kind of analogous to this. It really plays a very important role in this preparation. So some questions that people have asked is the evidence created at the top of this pyramid always the most relevant? And I think one of the issues is that this sort of rigid hierarchy really underestimates the limitations of RCTs and overstates the limitation of observational studies. It automatically assumes that observational research is inferior to RCTs and that all answers can be obtained from an RCT. And that's not true. And that really leads to the following, which is that evidence-based medicine is not always changing practice. And the question is why is that? So if you look at RCTs, there's no question there are difficulties. They were developed for drug studies, so they can be very difficult for surgical interventions. Allocation, for example, in surgical trials can't be concealed to patients and surgeons. Sometimes it's not ethical or feasible. So time to surgery studies where the outcomes are rare and where there's a lack of equipoise. There's also difficulties, if there are biases in terms of selecting and randomizing patients. And we know that orthopedic populations are very complex. The management options are complex, as are the patient populations. And in certain instances, expertise can be a major issue. I showed you a couple of examples where expertise is not an issue, but there are issues in other areas where expertise is a problem, and I'm going to be talking about that later on. So if you look at RCTs, feasibility can be an issue. So I talked about being successful in terms of doing clinical research, and having a good question and feasibility is critical. RCT can be challenging because feasibility can be problematic. So if you're randomizing patients, they're less likely to participate, and that can lead to smaller sample sizes that make it difficult to evaluate subgroups. So, for example, in the FAITH trial, we had a very large sample size, and we were able to evaluate subgroups. But if you're doing a trial of 100 patients, you're not going to be able to look at subgroups. Efficacy can be an issue. So, you're looking at doing studies, for example, in ideal conditions versus typical conditions. You're sometimes forcing clinicians to treat as they would not normally treat, and the trials can be costly and time consuming. If you look at surgical trials, typically they are not big enough. So the average surgical trial is around 90 patients, and that makes it really challenging to interpret the results. And a good example of this is in the SPRINT trial. So this is a study that we looked at doing over 1,200 tibia fractures that were randomized to reamed versus unreamed. And if you look at, a typical trial that's randomized, it's, 50 to 100 patients. So, if you look at the first 50 patients in the sprint trial, you see that there's an advantage with unreamed nailing. So you would think that based on those first 50 patients, what would happen if you recruited 1,200 patients is that the results would stay the same, and that the confidence interval would actually narrow and just solidify your outcome. But in what actually happened in reality was, I don't know why that's not sort of moving forward, but what actually happened in reality was that, with recruitment of more patients, we actually saw that it took 800 patients for the results to actually be stable, and the results actually favored reaming over non-reaming. So at 500 patients, the results were even between reamed and unreamed, and at 800 patients, you actually saw an advantage of reamed nails, and that stayed till the end of the trial. So if you'd based the study on the first 50 to 100 patients, you would have come up with a result showing that unreamed nails were better than reamed nails, whereas at 1,226 patients, the result, which was stable, was actually that reamed nails outperformed unreamed nails. And you see the same issue in small trials. So for example, this BMP study that was published that basically led to the approval of BMP2 in 450 patients, they actually showed that there was a risk reduction with BMP2 of 60%, where BMP2 was significantly better. But you can see the small number of events. There's only 41 events that led to that statistically significant finding. If you look at those events and you flip just 3 of those events, so 12 of the 135 BMP reoperations, if 3 of those, 3 more of were positive, suddenly you'd have a non-statistically significant event, which just shows how fragile the results are when the sample size is small. So really emphasizes the importance of having large studies, and having a small study can sometimes not be all that helpful. And so this study was actually repeated in open tibia fractures, and they actually showed there was no difference between BMP and control. Again, showing that the result in the first trial was actually quite fragile. So have RCTs always given us the answer? And I'm sort of building up to saying that they haven't really. And where I want to specifically focus on is the proximal humerus fracture, and to show that maybe there's a different way that we need to be going in some instances. So in terms of proximal humerus fractures, again, they're common. So if you want to be impactful, it's a good thing to be studying. If you look at their impact, complication hospitalization rates more than 50%, and basic decision-making continues to be controversial. So, should they be fixed or not fixed? What implants, if you're going to fix them? Should they get an arthroplasty or internal fixation? If they're getting an arthroplasty, what kind of arthroplasty? So lots of controversy. If you look at the evidence in 2021, you would basically walk away with the fact that there's essentially no evidence to support open reduction internal fixation in most patients with proximal humerus fractures. Despite this, we know that some patients benefit from surgery, but it's really unclear who those patients would be. And if you look at these X-rays, you would say that based on the evidence, all of these patients should be treated non-operatively. But if you took a 71-year-old female retired versus a 58-year-old male laborer versus a gym teacher versus a 48-year-old active banker and cyclist with this X-ray, do they all get the same treatment? And is that treatment non-operative? I would argue that it isn't necessarily so, despite what the evidence would be. certainly if you look at the evidence, pretty much all the randomized controlled trials show that for displaced 2 to 4 part fractures, there's no, advantage to surgery. But how good is the evidence? This is the largest randomized controlled trial, PRO4RCT, which was published in 2015, looking at open reduction internal fixation versus conservative treatment of proximal humerus fractures. 250 patients, 2 to 4 part fractures through the entire spectrum of age. They found no difference in functional outcomes, quality of life, or complications, and they found that surgery actually cost more after 2 years. So based on this data, they essentially concluded that for all comers, there's essentially no advantage to surgery. That's what many people have taken away from that particular study. But is that really true? Does surgery really have no effect in this patient population? And the other question is that, why then also is a large RCT published in JAMA not compelling evidence? So you're talking a high impact study published in a high impact journal, and it's a large RCT, granted not over 1,000 patients, but certainly 250 patients, largest trial that's been published in this area. If you look at, the trial a little bit more closely, you can see there are issues. So, 250 patients, recruited. Those 250 patients were recruited from a base of 1,250 patients. So only 20% of patients were recruited. And who was excluded? So 87 patients were excluded because they had a clear indication for surgery. So how can you argue that surgery has no benefit if you're excluding patients that have a clear indication for surgery? 117 patients excluded because of a lack of clinical equipoise. They recruited only 20% of suitable fractures, as I said previously. And then, if you look at, across all sites, a median of 5 patients per site and 1 patient per surgeon. So hard to sort of look at, a homogeneous patient population under those circumstances. Similarly, they had a primary outcome measure that was not designed for the trauma population. It was more for elective surgery. They sort of bundled all of open reduction internal fixation, nailing, and arthroplasty into the same group of operative. Didn't really consider, a reverse. And so as a result, a lot of people have really had issues with the conclusions. And if you look at, has this trial, changed practice? It hasn't. So for example, the study published shortly after PRO4 was published, they looked at, 110 patients undergoing surgery for proximal humerus fractures. And they found that, if the PRO4 conclusions were followed, 75% of those patients should have been treated non-operatively. And the authors of this study basically concluded that given the heterogeneity of fracture types in PRO4, there was specific subgroups that may have benefited from surgery, and this may not have been detected, essentially suggesting that there are patients that would benefit from surgery, and this tends to be what we're seeing globally in this area. And certainly, if you look in Ontario, where I live, this just shows the rate of fixation, in the sort of 2004 to 2012 range, and it's basically stayed around that 13 to 15% mark, even up to 2020. If you look at surveys of surgeons, really there's only consensus in terms of the minimally displaced fracture that non-operative treatment is indicated. If you look at all sorts of permutations and combinations of proximal humerus fractures, you get the complete, variety of surgical options that are being put forward for management, despite the fact that, people are claiming that surgery makes, no difference. Certainly, if you look at expert opinion, there are indications for surgery. So fracture dislocations, severe soft tissue compromise, valgus impacted fractures, head splits, significant displacement. And the other issue with respect to, open reduction internal fixation is that, expertise really is critical in terms of managing these. So in some areas where expertise is far less critical, it's been shown that there are technical factors that, play a major role. And if you're not following these issues, then that can eliminate any advantage to, internal fixation. It's also been shown that surgeon experience plays, a role. So for example, in this study, they showed that if you're doing, less than 50 shoulder surgeries a year, your outcomes are not as good. So, picking random surgeons, doing random operations, and then including them in a randomized controlled trial can have, an impact in terms of your, outcomes. So no question that, expertise is critical. I mentioned or showed those technical factors. You've got to reduce the fracture, have a calcar screw, have a good reduction. And if you don't, then you are going to have issues with fixation failure. So for example, if you have, tuberosity escape with plate fixation, is that a problem with surgery or the fact that you haven't managed to, control the tuberosity? And really, like it's about a lot of issues. It's not just the use of the plate. You've also got to, have the proper patient selection, reduce the fracture, make sure that the patient has the appropriate rehab. And so sort of just saying that surgery doesn't work, I don't think is necessarily true. So if you look at proximal humerus fractures, what do we know? Well, there's a lack of agreement on prognosis and the predictors of outcome. There's a lack of agreement on classification. The management options aren't straightforward, and expertise is extremely important. So what have we learned from the case of the proximal humerus fracture? I think what we need to understand is current practice, the population itself and its subgroups, and the predictors of outcome before you design new RCTs. Why, design an RCT looking at, plate versus nail when you don't even understand who would benefit from surgery? So I think it's really important to understand the role of patient, fracture, treatment, surgeon, and rehab factors in determining outcomes. We really need to understand why some patients are regularly excluded from existing trials. So is there a new way forward? Well, there's no question that high quality RCTs, if they're well powered, large sample size, pivotal trial, they are the gold standard for efficacy. However, smaller, inadequate ones shouldn't be treated as higher evidence than well-designed cohort studies. So a well-designed prospective cohort, I would argue, is better than a poorly designed small RCT. And I think it's important to bear in mind that RCTs may not always be appropriate or feasible for the objectives or the population. And I think there's growing recognition that RCTs alone are not going to fulfill all information gaps. So are there other options? Well, I think registries, are going to play an important role, as will prospective cohorts. And I'm just going to delve a little bit into this. So just an example of how a registry can help. So this is a registry study that we used using provincial data. So we have a large provincial database that links all patients that interact with the healthcare system in Ontario to each other. So there's linked databases in a system that is done to the Institute of Clinical Evaluative Sciences. So basically the entire population of Ontario is linked through multiple databases. So we can actually see what happens to, 15,000 proximal humerus fractures. So for example, we did a study where we wanted to evaluate complication rates of primary versus revision arthroplasty for failed ORF following proximal humerus fractures using this database. So we could look at, over 30,000 proximal humerus fractures, and we could figure out who got a primary arthroplasty and who got a secondary arthroplasty after failed internal fixation. We were able to show that, the complication rate was 3 times higher, with a secondary operation than it was with a primary. Many people have said that, fix it, and if it falls apart, you can always do an arthroplasty. But if you have that happen, there are consequences of that decision making, and that seemed to be the case whether you were dealing with reverse or a hemiarthroplasty. And so, our feeling was that, based on this data, a primary arthroplasty may be a better option for patients whose prognostic factors suggest a high complication rate following open reduction internal fixation. So if you're thinking, that bone quality is poor and failure is high, it may be better to go straight to an arthroplasty before doing internal fixation. Registries are very helpful because they provide you with, population-based data. Particularly if the data sets are linked, that can be very helpful. And you can, apply various AI and machine learning algorithms to actually potentially predict, risk. So we have this, study that we've just submitted for, publication, looking at that 30,000 patient database, and you can actually, apply algorithms to the database where you look at patient age, comorbidities, and various other factors to actually come up with a risk for treatment using various modalities. So rather than sort of making an arbitrary determination in terms of, surgery, no surgery, you can actually delve down into what actually might be, the best treatment option of all of the various different options. The other thing I want to talk about is prospective cohorts, and I think they do provide really important information. They observe the effects of different interventions on outcomes as they occur following the intervention. They contain very large and comprehensive sets of relevant variables. They allow you to assess greater heterogeneity of treatments in patients, and they can address some of the limitations of RCTs. And some have actually felt that they may actually be better aligned with the goals of comparative effectiveness research. In terms of levels of evidence, in terms of prognosis, this is actually level 1 evidence. So it's right up close to the top of that evidence pyramid. And the big advantages are they allow you to characterize the population. They allow you to define the course of the injury and the treatment, establish associations between predictors and outcomes, and measure and evaluate patients and circumstances in routine practice. They also, address a huge issue with respect to feasibility. So you're not randomizing patients, so patients are more likely to participate, and that potentially allows you to drive larger sample sizes. Clinicians can treat as they would usually treat, and the cost is less. I think benefits would be that you can examine multiple treatment comparisons, focus on multidimensional outcome assessment. They'd have higher external validity, and they may be beneficial for policymakers and for the development of clinical practice guidelines. And I think they're not meant to be mutually exclusive. They can complement RCTs. And so, for example, in the proximal humerus, I think once we understand prognosis a bit better, I think that's going to drive hypotheses for future focused RCTs. So if we can actually figure out, for example, who is best treated with surgery, then we can actually develop the focused RCTs to sort of define exactly what best surgical treatment option actually is. The other thing is it will allow us to understand heterogeneity, which I think is a big issue when you're looking at, RCTs. There have been a number of, cohorts that have been very successful. So the LEAP study is an example, the MOON study. So, this was a study that was, published a decade ago, looking at, characterizing patients with high energy lower extremity trauma, and led to, multiple articles that, show some of the issues that were addressed and have been really helpful in terms of understanding what happens in, severely traumatized patients that have traumatized limbs. So, what we're keen on doing in this area is, rather than doing a large RCT in the area of proximal humerus fractures, we think that the way to go is actually a multi-center prospective cohort study to address the issues that I've discussed. So we're going ahead with this Decipher study, which we're doing through COTS. And basically it's been created to determine exactly what drives outcome in proximal humerus fractures. We have a high level of funding from multiple agencies to support the study. I think it's going to be helpful in terms of providing clarity to this area. So 17 centers, 750 patients. We want to include all fracture treatment types, collect standardized follow-up data, and identify what really predicts outcome following each treatment type, and then identify the key subgroups that would either benefit or have worse outcomes with various treatment types. I think this is going to allow us to make some, real world comparisons. We're going to use propensity score matching and other confounder adjustment. Hopefully is going to allow us to, answer some questions around operative and non-operative treatment and various forms of rehabilitation. I think it's going to help us perform some exploratory analyses to better outline the relationship of these variables on outcomes and identify the subgroups that are going to benefit from future RCTs. There's no question that, cohorts are not perfect. They are, at higher risk of bias than an RCT. So design is important. So you want to carefully design the trial to maximize utility and minimize bias. They can only be used when the intervention is already regularly used in practice. So that's an issue. And there is administrative and patient burden. So I've talked about, how we're going to comprehensively look at these 750 patients, but all of these outcomes that we're assessing, they take time, energy, and cost to obtain. So the bottom line is sometimes RCTs are not feasible, ethical, or practical. Well-designed prospective cohort studies may be better able to make generalizable conclusions versus RCTs. Well-designed prospective cohort studies are necessary when RCTs have significant design issues. We feel that the hierarchy of evidence should be taken as a rule of thumb, but you should evaluate all types of evidence to make clinical decisions. Don't just consider the method, but the design of the work. And I think there's a real increasing role for well-designed prospective cohorts and registries for decision-making and generating hypotheses for focused RCTs. And I think that is really the key takeaway message for me in this talk. Thank you.
Great. Thanks so much. That was an excellent overview, excellent talk. And I think we have some time to open it up for questions or comments. If you would like to unmute yourself, and I see Dr. Miklau just unmuted himself, so maybe we'll start with you.
Yeah, thanks, Drew. First of all, Emil, thanks again for providing this time for us. It's really great to have you here. There are a bunch of questions that I could ask you, but I think the one that I would like you to comment on, because our group does a decent number of international studies as well, and that you brought up a little bit about the financial challenges that one might have in running these studies. Those are inherently more expensive to run, and they're difficult. You've been involved in a lot of them. And I was wondering if you could comment on the role of, financial viability in designing these studies.
Yeah, I mean, I think that's a huge, issue. And I think, that you almost have to take a bit of a multi-pronged approach. I think, the more centers you have, particularly if you're international, I think to some degree you've got to make the study simpler. It's really hard to, create, a study where massive amounts of information are required, and yet, you're wanting to recruit, thousands of patients. I think the bigger the trial, the more you, to some degree, need to simplify it, and to some degree, that will help on the finances. I also think that, getting pilot data is really, really important. So, for a lot of our studies, we, typically will tend to get either, local or, regional grants that will allow us to get pilot data. And, that pilot data, can sometimes be really compelling in terms of getting, the larger funding. Sometimes industry, can be very, helpful in terms of, driving, research, depending on what the, research question, is. So I think, not sort of excluding, industry from the thought process, I think is important. But I would say those are sort of the three key things that I would sort of look at. I think a lot of it is about, exactly what's the plan for the research in terms of, it sort of being, multinational, and how complicated is this going to be, and simplifying, and then getting pilot data to sort of leverage and get more funding, I think would be critical.
Emil, I have a couple.
Yeah.
I have a couple of questions for you. I raised my hand there, Drew. One is, I've always been I've marveled at how collaborative the Canadians are in running these clinical trials, really at kind of low cost, but asking good questions and really building a sense of mission and equipoise around questions that you all have agreed to randomize patients to. Is this just an inescapable problem with the independent, American spirit, that we just can't build that sort of consensus around what the important trials are and getting behind them and doing them in the States? I mean, that's not an absolute. I mean, I'm discounting some significant efforts and collaborative efforts, but with you coming, and assuming the helm for the of the OTA in the very near future, what can we look to as ways of building that sort of consensus and teamwork around answering some of the most important questions that face our field?
I think it is possible to get there. I mean, I think that there have been, a couple of barriers in the past that we've seen. One of them is, just getting, credit academically. So, people are always worried that if they don't, assume the role of the PI or are involved in some way that suggests that they are leading the work, that somehow they're not going to get the academic credit. And I think, one of the things that's really key is for, people to realize that, if you're helping me do my study and I'm helping you do your study, we both win. And you don't have to be, leading every initiative, to be academically successful. And certainly, if you look at, clinical research, I mean, it sort of, to some degree, flies in the face of kind of what universities look for. I mean, they look for one person, API, who's kind of the leader, but that's not how clinical research works. And I think some of that then becomes, education, emphasizing the importance of a team. And that's the first thing. I think the second thing is, you're right about, independence and spirit, and people sort of, getting in a room and, claiming that, that they know the answer to a problem, et cetera, et cetera, et cetera. I think that to some degree, though, it's like Rome wasn't built in a day, and it's a kind of an iterative process. So most of what happens in our setting isn't necessarily because, we somehow get along with each other better. What happens is that we sort of work at it. So, I mean, I can, give you a good example. I mean, I had a, study that, I wanted to do, looking at an osteobiologic and open tibia fractures. I went to COTS, and I literally presented this idea, which I thought was, the world's best ever. And I mean, I literally had 35 surgeons tell me I was crazy. So, when 35 people are telling you, in unison that something you're doing doesn't make a ton of sense, then, it's time to sort of go back, reflect, and see if it, can be addressed in, a different way. And that's typically what happens at COTS. So, we'll have 2 or 3 meetings where, we'll hash through ideas and get it to, an appropriate, research question, and then, work through the protocol, et cetera, et cetera, et cetera. So it's kind of that iterative process that occurs over multiple meetings where everybody sort of gets a sense of consensus. And then once there's a consensus, then, everybody gets behind it if they're interested in it. And even then, we don't necessarily have, 100% consensus, but usually there's enough groups that are behind it that you can do it. So, I mean, if you've got 50 students and, 40 like the idea and want to participate, then you've probably got a viable trial. So I think it speaks to having a large enough group with people that are interested, that want to do it over a sustained period of time, and then getting to some consensus.
It's great. I have another question, but I'm not going to hog you, Emil. I think I see Mayor's hand up, so why don't you go for it, Mayor? Come back to mine if we have time.
Thank you, Emil. Great talk. Really resonates with a lot of the things that you said. I wanted to ask you about, you said, I think very rightfully, that for an RCT to work, we have to have a good understanding of the predictors and their relationship to prognosis. Now, in that sense, I think my question is, how do you know that you really understand the relationship or the predictors and the relationship to prognosis? I would argue that if you really knew the relationship, you probably wouldn't need an RCT in the first place, because you already know what what predicts prognosis. And the other thing is in the same thought is, how do you measure expertise? Because you also said that it's very important that expertise will not be an issue for an RCT to work. And then how do you measure a surgeon's expertise?
Yeah, and that's, I think, a really good question. I mean, in terms of, expertise, one of the problems is that, typically we'll use experience as a surrogate for expertise, but those two things aren't necessarily aligned. And I think that's something that has to be figured out. So at the moment, when we sort of look at expertise, we sort of say, okay, well, you've done like 50 of these, and you're doing 5 a year, or you're doing 10 a year. But, who knows necessarily, whether you're doing them well. I mean, we have some ability to adjudicate that. So, we'll often have blinded adjudication of x-rays and so forth. But, part of the problem is that's after the fact as opposed to, before the fact. So I would say that there's still a lot of work to be done in that area, but it definitely is something that needs to be, considered. So, I think, if you look across surgery, if you're going to do, for example, an RCT in acetabular fracture fixation, you're going to have to make sure that the people that you are, including in your trial as the surgeons, actually reflect accurate ability to do, acetabular fracture fixation. Comes a totally different story if it's as simple as, dropping a bone substitute into a wound. So, expertise can play a large role in some settings, and not in other settings. Prognosis, again, is a difficult sort of thing. I mean, I think in some situations we understand it, and in some areas it's a complete black box. So like I look at areas like the proximal humerus, pelvis trauma, where we have a real lack of understanding in terms of why it is some people do okay and others don't. I think we need to sort of figure that out. But in terms of sort of defining exactly what prognosis is and whether it's acceptable or not, I don't think that's known as yet either. So I think there's a lot more work that needs to be done on that front.
Other questions, comments from the audience?
Yeah, I can add another question in that line of thought, is that when I like the prospective cohort and the thoughts behind it. And you're saying, well, we have to protect from bias, but isn't bias in the case of surgical trials really correlated to your experience? So I would hope that the surgeon that's experienced is very biased toward doing one thing for one patient and the another thing for another patient. So how do you think we capture this experience in medical trials?
Well, I mean, if you really want to eliminate bias, I mean, the best way to do it is with an RCT, because theoretically everything is.
Why eliminate it? Because we're surgeons, we have to be biased.
Well, the problem then becomes is that, at the end of the day, that bias is then being reflected in the treatment, and that isn't necessarily generalizable in all settings. So I think, a prospective cohort is really valuable as it relates to determining prognosis, but is not so valuable, if you're trying to prove efficacy of treatment A versus treatment B. There are just too many issues in terms of surgeon selection bias and various other forms of bias that contaminate a prospective cohort. So I think it's a good enabler of hypothesis generation, but it will never sort of give you absolute definitive answers as it relates to efficacy, because I think there are bias issues. Now, you can control, and then we can spend an hour talking about how you would control for that. But there are issues that, are more significant than they would be in an RCT.
Drew, I know we're out of time right now, but I just want to put one other idea out there, which you might consider kind of, somewhere between cohorts, the attractiveness of cohorts as well as RCTs, which are proliferating in other areas of medicine. They're called SMART trials, or sequentially randomized trials, which don't necessarily randomize patients to a specific treatment. They take into account all of the heterogeneity factors that you alluded to, and they will randomize patients to different treatment algorithms. So it's a bunch of if-then statements, and that there can be 3 nodes in the allocation of treatments to any one of these treatment groups. They are in the era of precision medicine really considered, in some ways maybe the future of what RCTs should be, because they reflect real world conditions much better than a static assignment and a point treatment time to one or another treatment. So you're going to hear about these more. If you pick up the latest edition of JAMA or a New England Journal, you'll see these trials starting to pop up. And I think there's something that's on the horizon for us as well.
I would completely agree with that, Sam.
Great. Well, Dr. Schemitsch, thanks again so much for joining us. Certainly wish you could have been here in person, but appreciate you doing this format. And thank you for the excellent talk, and thank you all for joining this morning.
Thanks, Emil.
Thanks so much. I really enjoyed it.
Bye.
Okay.
Emil, thank you
So much.
Thanks.
Thank you, Emil.
Appreciate it.